Well, our study mainly explored the baseline knowledge and attitudes and practices towards our advanced care planning of resident trainees in our hospital. It was mainly an exploratory study done through an online self-administered questionnaire. And these questions were geared towards assessing what our residents knew about ACP, how often and how comfortable they were in conducting such planning with their patients, and the barriers and facilitators to ACP among these residents. To discuss their differences, we need to see how they are similar first. So actually, palliative and hospice care are both geared towards ensuring patient comfort and maximizing quality of life. But the difference is that palliative care focuses also on curative treatment, and still the goal and interventions are targeted towards the disease itself. On the other hand, hospice care shies away from curative treatment, and the interventions mainly focus on comfort care and transitioning the patient as smoothly as possible to end of life. Advanced care planning can be seen somewhat as a contract in between the patient and the physicians involved and the institution that they are in. This is to make sure that the interventions that the patient will be receiving is in line with his beliefs and values and priorities as he goes through the serious or chronic illness that he has. In the Philippine setting, at least, advanced care planning mainly includes clarifying directives with the patient with regards to number one, who will be the decision maker should he or she lose the ability to make decisions for herself. And number two, opting in and out of certain interventions or medications or diagnostics, such as CPR, intravenous fluids, endotracheal intubation, vasopressor support, or hemodialysis. In our study found that the residents trainees had average baseline knowledge about ACP, and that actually most did not have any formal training for its conduction. However, even if they didn't have any sort of training with regards to ACP, a lot were actually willing to undergo such training to improve patient care. Interestingly, our study also found that although the residents claimed that they are comfortable in conducting ACP with their patients, most actually did not prefer to discuss it with them for fear of causing distress further to the patients and their families, and also the time that is involved in conducting ACPs. In the Philippines, ACP is relatively a new concept, and I think that it can be improved in two ways. Number one, having a uniform ACP document across the country and formalizing the process of conducting ACP. Currently, ACP forms here in the Philippines are vary per institution or per hospital, and no uniform protocols exist. So I think having that formalized in across the country would really help. Secondly, avenues for training in conducting ACP. While again, in our study, the doctors here said that they were comfortable in conducting ACPs. I think the doctors here would benefit from having formalized training, for instance, how to initiate the topic of discussing ACP or how to go about discussing its terms with patients, especially in our culture where end of life or death is still a conversation that we tend to shy away from for fear of causing added distress to families and patients. So far, there really are no avenues for training physicians in ACP here in our country. Mainly, advanced care planning is taught to residents who are training in residency in family medicine as part of their competency in palliative and supportive care. However, residents in other disciplines, like as in general medicine or surgery, do not have formal training. And I think that's really a thing that our country needs to improve on. Nothing much, but that hopefully our study piques more interest in and bring about more studies on ACP, especially in countries where it is relatively new, like as in the Philippines.